So thanks for joining us. My name is Prashant Kaul. I'm an interventional cardiologist and the director of the cath lab at the Piedmont Heart Institute at Atlanta, Georgia. And we're here at the Piedmont Napa Cardiology Conference 2018. I'm here with my good friend and colleague, Dr. Alan Yeung. He's professor of medicine at Stanford and the chief of the cardiovascular division there. Alan, thanks for joining us.
Thank you. Thank you for having me.
So I just wanted to ask you your thoughts on stents. So, we've come a long way since Andreas Grunzig in 1977 and his initial balloon angioplasty work. And now we're on second, third generation drug-eluting stents. There's been a lot of press recently, some positive and some negative as well. How do you counsel patients who you are seeing in clinic on whether or not PCI and stents in particular are a good option for them?
Right, thank you. I think, stents obviously is a great breakthrough in how we treat blockages in the heart arteries. But at the same time, it's not a magic pill, magic device that make people live forever. So I think we have to put that in balance. And most of the time when we talk to patients that talk about stenting procedure for the coronary artery, is really to patients that have symptoms. These are patients in the clinic, they're coming through, they developed exertional or processes that basically make them have shortness of breath and most of the time also angina, chest pain, chest pressure. So the first question is that, are they symptomatic? If they're symptomatic, and then from tests that we conducted, they have signs that the heart is not getting blood flow. The two have to come together, meaning that if you have either one and not the other, there's concern and therefore you need to talk more what is better. After that, I think we have to talk about medicines. Are they on the right medicines that can prevent new blockages from forming, right? Because stenting is very good in fixing arteries that are blocked now, but they are not very good in obviously fixing future blockages. So it's very important to have a conversation with the patient that what caused that blockage in the first place and what we can do to mitigate, decrease the risk of having blockages in the future. So after that discussion, they understand what they need to do. Then we talk about what the stent actually can do, which is to relieve the blockage in the heart arteries, getting blood flow to the heart artery better, so relieve the ischemia, the process of not getting blood flow in the heart. And therefore, at that time, symptoms likely will be improved significantly. But as I always said to the patients, that rubber has to meet the road after the procedure. We think that's a spot, we fix the spot, and therefore after that, they have to test it out like a new car, do their activities, and I would say 80, 90% of the time, the symptoms will be gone. And sometimes 100% depends on how we think the process is. So I think by setting the right expectation, what the patient also need to do, take the medicines to lower the cholesterol, change the risk, because stenting is only for one spot. We cannot stent everything in the heart arteries. So therefore, I think it's important to have that conversation with the patient that what they need to do as well. And also talk to the primary care doctors, referring doctors, that to have a sort of a three-way communication that they know that we have fixed part of the artery, the patient also need to do their part as well.
So, there are a number of other options also, just short of sending somebody to the cath lab. And so there are non-invasive testing, there's stress testing, we do a lot of CT angiograms now, and there's also CT FFR. And there's also the option of doing FFR testing in the cath lab. So with that in mind, how do you make the decision about whether or not to jump in straight away to go to an angiogram versus some other non-invasive testing?
I pretty much have a non-invasive testing in between. From the symptoms and also risk factor, we think they have a high chance of having blockages. The next step is usually not at the cath lab. Next step is usually some sort of non-invasive test. So we obviously, if the person can exercise, and exercise echo will be very helpful, no contrast, no radiation. CT is obviously getting quite a bit of, with better resolution and able to get us sort of anatomical information. That's also up high. We can also get a calcium score as well in an appropriate population that we can understand their risk and also convincing the patient their risk is higher than they thought. So CT is also in there as well. Then after those tests, then maybe going to the cath lab, depends on what we found. So the question is really whether it is a stress type of test, nuclear stress test, echo stress test versus CT. I think that's really the sort of balance right now. Sometimes insurance have a big barrier in terms of getting CT. But at the same time, in younger patients, not so convinced that they want to go to cath lab yet, CT could be a very good combined evaluation because then you can see the coronary arteries. Let's say it's normal, then you're done.
Yeah.
So a lot of atypical features, or they are. So I think the two sometimes complement each other, the stress test and the CT. But the trouble is that the more tests you order, more expensive, more time for the patient as well. So we have to kind of pick, for that particular patient, what we think is the best non-invasive test to go forward.
And then finally, when you are in the lab and you see a lesion that you believe is hemodynamically significant and causing this patient's symptoms, how do you make a decision about the type of stent? And in today's era, are you predominantly using drug-coated stents?
Yeah. So when we see a blockage in the coronary angiogram, we always ask ourselves, is this blockage really the culprit? Is that the responsible blockage? Especially there's some minor ones otherwise. And we're fairly liberal in using a technology, the FFR, the pressure wire, to evaluate that lesion. Unless it's 90%, very obvious, and it helps us decide. Also, sometimes we see a lesion that is quite complex, but moderate in nature. That if you test it with FFR, it turns out that it's sort of marginal, may not be very significant. Medical therapy could be an even better thing for that patient rather than an aggressive multi-stents sort of approach. So I think that's kind of one part first. Do we want to fix it? And the second part is what stent to use, and pretty much we use 100% drug-eluting stents now of various brands. And I think the difference between the current generation drug-eluting stents are not very different. So I think we just pick one or the other. Depends on the length, the size, and the ability to take the dual antiplatelet therapy afterwards as well.
Fantastic. Alan, thank you
very much
for joining us.
Thank you.
Thank you.